Good evening all. A very warm welcome to this webinar today. And on behalf of Jagsonpal Pharmaceuticals, I welcome you all to the webinar today. We have with us Dr. Seema Mittal. She is past president, Rewari Obs Gyn Society and director, Lalita Memorial Hospital at Rewari. Let us welcome Dr. Seema Mittal, and please start the proceedings, ma'am, for the webinar now.
Welcome everyone. Friends, I start this webinar with a thank you note to our esteemed chairperson, FOGSI Imaging Committee, Dr. Bela Bhatt, who has been pioneer in filling up all the lacunae, and this is the 5th episode of this webinar, which aims to just share knowledge, and very effectively she has made the effort to fill in all the gaps. Thank you, ma'am. And friends, I'm super excited about that date today because we have all the new FOGSI team with us, and we have a dynamite our Dr. Jaydeep sir, Dr. Madhuri, and Dr. Girija Wagh. Thank you once again, Dr. Bela, and may I invite Dr. Bela to initiate this very useful, important webinar, and thank you for all your efforts. You are incredible. Over to you, Dr. Bela.
Thank you so much for those kind words, Dr. Seema Mittal, who is a very good friend also, and who is the force behind this entire series of Filling the Lacunae. So on behalf of FOGSI Imaging Science Committee and of course the Rewari Obs Society and IFS Haryana chapter, I extend a warm welcome to all the delegates, all the seniors, all the colleagues and friends. Well, as a chairperson for FOGSI Imaging Science Committee, we have been doing a lot of academic activities since past 2 years. But this is special because this is first of year 2024. And I'm very glad that I'm starting this activity with none other than Rewari Obs Society, Dr. Seema Mittal, and all the friends of Rewari Obs Society. Well, as always, this time also the topics chosen by Dr. Seema Mittal are very useful to practicing obstetricians and gynecologists. And we have a combination of obstetric topics and gynec topics. So we have an ultrasound in obstetrics, third trimester scan, and we have 2 gynec ultrasound topics in today's series, which I'm sure everybody will definitely benefit with. And I'm very thankful to all the FOGSI office bearers, the new team, the president, Dr. Jaydeep, the Secretary General, Dr. Madhuri Patel. I'm very happy to see Dr. Girija Wagh here today with us. So, Madam, it's absolutely my pleasure and honor to work under your guidance, because we know Dr. Girija Wagh is a brilliant academician and a very dynamic Vice President of FOGSI 2024. Dr. Seema Mittal, can you please introduce ma'am formally to all of us?
Thank you, Dr. Bela. And here I am, Dr. Seema Mittal. I am infertility specialist, and my passion is about making babies and bringing them to the world. So I welcome Dr. Girija Wagh, our Vice President for year 2024, and she's gynec obstetrician and infertility specialist. She's Professor OBGY, Bharati Vidyapeeth, Pune, and Senior Consultant Cloud9 Hospital. She's Chairman Medical Disorder Pregnancy 2012-16, Assistant Coordinator National Eclampsia Registry, Member Central Supervisory Board PCPNDT, National Mentor Lakshya. She's peer reviewer all our journals, Jogi, Bijog, and EJOG, and she's Regional Director Study Medic, Anandiben Joshi Award winner for excellence in medical services. And I'm sure FOGSI will see a new era under her leadership. It's a pleasure to have you with us, ma'am. Please share your words of wisdom with us. Really thankful to Dr. Bela for bringing you all to us, to Rewari Obs Gyn Society. Over to Girija, ma'am.
First and foremost, extreme congratulations to both you, Dr. Seema Mittal and Bela Bhatt, for coming up with such a wonderful CME, and especially coming from Rewari, so it's sort of a top of the country from where we start. And congratulations for bringing up such wonderful program together and also organizing it in a very seamless fashion. I'm sure all our members are going to benefit, and we are really blessed after COVID, I think, where we can connect to such far off places just by being on the online portal, and we must make most of this. Wish you all the best, and I'm sure that this particular CME is definitely going to leave a mark on our minds and definitely help us to improvise our practices better. Wish you all the best. Thank you.
Thank you so much, ma'am. So may I invite chairperson for this session, Dr. Alka Yadav and Dr. Pooja Sinha. So we have Dr. Alka Yadav, who has special interest in high-risk obstetrics, and she's our president. Dr. Pooja is a helping hand and a shoulder where you can really put your hand. And she has contributed to various book chapters, co-authored, and she has publications in reputed journals. And she has special interest in fertility and fetal medicine. And she's life member of FOGSI IFS, ISOMS, SFM, her Obs Gyn, and she's executive member of a Haryana chapter, and very, very enthusiastic worker. So, Dr. Pooja, you get the liberty to introduce our very dynamic, versatile darling, Dr. Bela.
It is my great honor and pleasure to introduce Dr. Bela Bhatt, who's MD and who's an FICOG. She is a consultant at the Fetal Medicine Center in NAARI, Mumbai. She's certified from FMF for fetal abnormalities and nuchal scans. She's a life member of Society of Fetal Medicine, Joint Secretary of AFG Mumbai. She's Managing Council member of ISPAT. She has won various prizes, one of them being CS Dawn First Prize at AICOG 2018 Bhubaneswar, and the first prize winner for FOGSI Has Talent National Competition. She is also the national convener for FOGSI Superstar Competition 2019. It is my great honor and privilege to welcome you, ma'am.
Thank you so much. Here we go. So when we talk about third trimester, so we know that a lot has been talked about the first trimester scan, that is a nuchal scan, the second trimester anomaly scan, 18 to 22 week scan, but not much has been talked about third trimester scan. But well, taking things lightly must lead to big difficulties. Third trimester scan, like this ocean, has so many things in its store. And that's what we are going to learn today, as to what all information we can gather from third trimester scan from more than 28 weeks till term. So it's not just 1, 2, 3, 4, multiple information that we can get. Number one, fetal viability, of course, at any ultrasound. Presentation, which is very, very important in third trimester, more so after 32 to 34 weeks, where sometimes you have difficulty on clinical examination, where ultrasounds comes to help you to find out exactly whether it's breech, cephalic, transverse, etc., etc. If a woman does not have had a previous ultrasound scan, which still occurs in our country, it's not uncommon to see a patient coming right in third trimester with no previous scans, not sure of LMP, where assessment of gestational age is also with the help of ultrasound. Exclude suspected multiple pregnancy also. Biometry and growth, of course, to look at the interval growth charts, diagnose some growth disorders like fetal growth restriction or large for gestational age, late onset anomalies or follow-up of previously detected anomalies, placenta, previa and present accreta spectrum, like a cervix. So everything we are going to talk about in details. And of course, there's some such special situation where you'll be doing ultrasound in third trimester, like antepartum bleeding, reduced fetal movements, or preterm rupture of membranes. But I can't go into details of this. So let's start with the biometry in the third trimester. So we know that in this clip also you'll be able to see this is a transventricular diameter. So you have to start with your biometry with your biparietal diameter on either the transventricular or transthalamic view, which is an axial scan, view. And on this, these two measurements are to be taken, following which we go to the axial scan of the abdomen, and we take the anteroposterior diameter of abdomen and transverse diameter, followed by femoral diaphyseal length. So these are basic 4 measurements, the BPD, HC, AC, FL, right? The machine will give you automatic AC once you take anteroposterior and transverse diameter of abdomen. Or you can use ellipse method, either ways, whatever you are comfortable with. So that's how we do the biometry. Now, what about dating in third trimester? As I said, sometimes patient presents at 7 and 8 months, LMP not known, no previous scan available. How to date? The fetus is asking, how old am I? So what are the methods with which we'll be able to find out the dating in third trimester? Well, the recent guidelines which have come up on 2nd of January 2024 by ISIOG tells us that in third trimester for dating, we must use head circumference plus femoral length, or if the FL is not available, only head circumference for dating. But again, it tells us that though this is ranking highest in recent systemic reviews, it has variation of 15 days plus minus at 32 weeks as far as dating is concerned. So it's not very confirmatory method, but this is the base that is available at present. So what do we do when we have no other previous scan? I'll do the scan. I'll mention in the report that the gestational age can't be ascertained as the patient is not sure of dates, no early scan is available. But the fetal size in my today's scan is so and so. And then I mentioned that a rescan after 2 weeks is advisable to confirm gestational age. So I'll rescan this patient after 15 days. And if the interval growth is normal, then I will assign the ADD to this patient and accordingly will monitor the pregnancy in the third trimester. What if the patient still comes further late, around 34, 35, 37, sometimes 36, 37 weeks, where the head is deeper in the maternal pelvis? I'm sure practically we all have faced this problem when we are doing scans near trump. So the head has gone in the pelvis. You don't get exact axial view. You can't get the proper standard BPD and OFD. Here, even the transcerebral diameter, which helps us because it is the prediction is as high as 95%. So these are the various parameters which are going to help us in dating in third trimester. Now, do we have any other rescue points in ultrasound to find out the dating? Yes, we have some bone ossification centers which tells us roughly the gestation age. So the distal femoral epiphysis will be ossified by around 32 to 33 weeks. The proximal tibial epiphysis is ossified around 34 to 35 weeks, and the upper humeral epiphysis will be ossified by 37 weeks. So again, these are all methods which can roughly give you that the gestational age is around so and so if you find the ossification center. So that was the basics of biometry and dating. Now we go on to some very other important aspects. What about diagnosis of growth disorders? Well, whenever we are monitoring a growth of a fetus, two most important parameters are looking at the centiles and growth charts. We know we cannot assess a growth of fetus if we do not have growth charts, and the abdominal circumference and weight are the two parameters which are going to help us diagnose late onset fetal growth restriction, because we know that if the AC or EFW is less than third centile, it's late onset fetal growth restriction. Or if ACFW is less than 10 centile with, or ACFW crossing 2 centiles, or CPR less than 5th centile, or umbilical artery PI more than 95th centile. These are all criteria, standard international criteria to diagnose late onset fetal growth restriction. So we need centiles and growth chart for sure. Now, once we know that this is a high-risk pregnancy or fetal growth restriction, then of course we need to look at the multivessel Doppler, in which we include umbilical artery, middle cerebral artery, ductus venosus, and of course maternal uterine artery. So here we are trying to find out whether the fetus is okay inside or not, or how about the well-being, because we know the most important aspect of management of fetal growth restriction is deciding timing of delivery, right? So I'll quickly share this case. For some, it may be repetition, but I think it's very important because we get some very important messages from this case. So this patient, 34 years old, primary, with conception after 14 years of infertility, first time was referred to me at 32 weeks, 5 days. Now, when I looked at the dating, third month scan was available. So dating was confirmed based on the nuchal scan. And according to that, the expected birth weight was at third centile. However, the Dopplers were normal. So this was diagnosed as stage 1 fetal growth restriction. Patient was advised about keeping kick count and repeat Dopplers after 1 week. Unfortunately, next week, I couldn't go to that center and I couldn't reassess this patient. But the patient gets a scan done by a radiologist, who reports in the report that weeks on ultrasound corresponds with weeks of gestation and there is no brain sparing effect. But 3 days after this, the patient goes with reduced fetal movements to the obstetrician, and the sister here's the maybe perhaps the uteroencephal as the FHS, the emergency section was done, but the baby was already stillbirth. So here there is no blame game. What we are trying to find out is what went wrong and what could have been done in order to prevent this IUFD, and is there any way we could have prevented this? Let's look back at every finding. So now this patient had one nuchal scan done, one anomaly scan done, one scan done at 28 weeks as well, in which again, it was reported that the growth is normal. But when I looked at the centiles, the EFW was at 3.3 centile, AC was at 5th centile. So this is not normal. Ideally, what we do is we add this with the Doppler to find out whether there is actual fetal growth restriction. So which was not done. So the first message here is whenever EFW or AC is less than 10 centile, look at the Dopplers. Always look at the centiles, not weeks of gestation in your report. Look at it is also the responsibility of obstetrician to look at the centiles in the report. Here we can see the centiles are 3.3. AC, always look at the centiles, it was 5.3. So you have to order Doppler in this and try and find out whether baby is having fetal growth restriction. Always look at centiles. Now, when patient came to me at 32 weeks, 5 days, the Dopplers were normal. Here you can see the umbilical artery Doppler is normal. There is good diastolic flow. The MCA Doppler is normal with high PI. That's normal in a MCA PI. So this is what the patient was advised. Now, what happens after 1 week? Patient comes after 10 days instead of 1 week. But at 34 weeks, when the radiologist reports that there is no brain sparing effect, actually, when we look at the pictures, it's very, very obvious that umbilical artery PI has increased, and in middle cerebral artery, the diastolic flow has increased, which shows brain sparing. So let's compare this ultrasound done at 32 weeks, 5 days, and this is 34 weeks. This is umbilical artery, normal diastolic flow, normal PI. Here the PI has increased, umbilical artery. Look at the MCA PI at 32 weeks, 5 days. Normal low diastolic flow versus increased diastolic flow in MCA middle cerebral artery in 10 days. This is the changes that we see in just 10 days. Pathological changes. CPR going below 1 centile in 10 days. At 34 weeks, CPR less than. This is obviously telling that there is brain sparing effect. This is a late onset fetal growth restriction, where we all know CPR is very, very important. The baby is screaming at the top of his voice, monitor me, close me, or I'll die. Ideally, what should have been done? Well, all these Doppler signs should have been taken seriously, which were ignored. At 34 weeks, either patient should have been admitted and daily CTG should have been done, or steroid and deliver the baby. We know 34 weeks, all the NICU be able to salvage this baby. So, based on the findings, I request all the obstetricians to always look at your images, look at the centiles of growth, centiles, and look at the PI values and discuss with your sonologist as to what are the changes. Okay. So as far as late onset fetal growth restriction that develops after 32 weeks, very, very important. Always order a growth scan with Doppler at 32 to 36 weeks, because otherwise we are going to miss all these late onset fetal growth restriction. And why is it important to pick up these? Because out of all fetal growth restriction, only 30% are early fetal growth restriction. 70% of fetal growth restriction are late onset after 32 weeks. And they are responsible for 40% of stillbirths, which we say there was no cause. No, there was a cause. We didn't do Dopplers. We didn't follow it. We didn't monitor the fetus well. And that's the reason there was stillbirth. These are totally preventable causes of fetal stillbirth, late stillbirth. So, well, we all have knowledge, but knowledge is a treasure, but becomes ignorance if not put into practice. So always question, look at the report carefully, question all, look at the values, look at the MOMs, look at the PI, and discuss with your sonologist whether we can extend the pregnancy for a week or we need to monitor more closely. That was about fetal growth restriction. When we talk about growth, various problems in the growth of baby. We know it's not just small for gestational age, but when the birth weight is more than 90 centile, or when AC is more than 75th centile, from 29 to 33 weeks of gestation, that is called large for gestational age. And now what is the significance of this? Well, we all know India is becoming capital of diabetes, which is not good. So even the number of gestational diabetes patients are increasing. So how can we pick them up? Of course, we should have done a PG2BS in the first visit. But even if it is normal or if it was missed, when you look at the growth at 28 to 30 weeks, if the AC is crossing 75th centile or EFW crossing 90th centile, or if there's isolated polyhydramnios without any anomaly in the fetus, it's a red signal. It tells us recheck the sugars. Again, do your 75-gram PG2BS and try and find out whether the patient is gestational diabetes, because again, these are the patients who will go for sudden stillbirth because of gestational diabetes. So look at it, look at the sugars. If the patient is GDM, start monitoring and managing well these patients to avoid any kind of mishaps. So, well, our question when we started was, how essential is the third trimester scan? Well, for shock, it's very, very important. But we are friends, we are just halfway. We still gather so many more information from third trimester scan. So what is it? Late onset anomalies. Well, friends, for years, we used to always rely on our 20 weeks or 18 to 22 weeks anomaly scan, where we can find out almost 90% of anomalies. Then we switched to our early anomaly scan at 12 weeks, where at least 50% of anomalies can be picked up. But with all this, we all know that not all anomalies can be picked up even at 18 to 22 weeks, because there are certain anomalies which are going to be late evolving or late detectable in late second or third trimester. And that is from 22 to 36 weeks till term. And therefore, remember that late second and third trimester scans are not just growth scans. We are not just looking at centiles. We are not just looking at the growth charts. We are also supposed to look at the anatomy, because so many anomalies, CNS anomalies, some of the ventriculomegalies, intracranial cysts, absent corpus callosum, some intracranial hemorrhage, microcephaly, craniosynostosis, cerebellar hypoplasia. So many of the GI-GU anomalies, torch infection and associated anomalies, ovarian cysts, cardiac rhabdomyoma will all be detectable only in late second and third trimester. So we cannot just look at the growth and let the patient go off. I'll discuss with you quickly some of the anomalies which were picked up in the third trimester. This patient was referred to me at 33 weeks, 5 days, primigravida, non-consanguineous marriage with mild ventriculomegaly. Now, the anomaly scan, which was done at 18 weeks, was normal and would have been normal because there was one evolving anomaly. What was that? See, normally in a fetus at 33 weeks, I should be looking at the CSP like this. It's a box which interrupts the mid-FOGS like this, right? But in this patient, I couldn't see the CSP here, right? And I could see the teardrop lateral ventricles, which tells us that there is something wrong with the corpus callosum. This is a CNS anomaly. And when I tried to look at the mid-set section, there wasn't proper pericallosal artery that was seen, a small dysgenetic kind of CC anterior part, just the very, very anterior part of corpus callosum was seen. And when 3D rendering was done, I could see a kind of ethmoidocele kind of mass which is sitting on the nose of the fetus. So I know for sure, and with the depressed nasal bridge, which is very, very obvious, and hypoplastic nasal bone. So we know for sure that this is a major CNS anomaly. And why is it important to pick up at 33 weeks, 5 days? Well, we know that the chance of genetic association with CNS anomaly is very, very common. I know that maybe we could have picked up little earlier, but better late than never. Even if it is picked up in third trimester, it's better to counsel the patient to do genetic testing and try and find out the cause, because it also has bearing on where to deliver the patient, whether if there is any kind of operative delivery which is required, whether the patient is ready for that, etc., etc., etc. And of course, it is going to lead a lot in for prognostication for next pregnancy. So either you can take amniotic fluid, or if at all patient goes to court and gets permission and terminates, at least fetal tissue DNA should be stored, which at the later date can be tested and to find out whether there's any genetic anomaly. This was a patient which presented at 29 weeks, 5 days. Anomaly scan at 19 weeks was normal. But at 29, what I see is, as you can see here, there was bilateral hydronephrosis with keyhole bladder. This is a very, very old case, 6 years old case, keyhole bladder. And not only that, I could see a posterior urethral valve actually, which is there in the urethra. So I know for sure this is an obstructive uropathy, which is giving rise to hydronephrosis and keyhole bladder. So this was a case of lower urinary tract obstruction, and the patient was counseled about it. Antenatal pediatric urosurgeon was consulted, and then patient was weekly monitored for growth, hydronephrosis, and more so for LycoRed, because I know that anytime there can be severe oligohydramnios. So at the 29 weeks, the LycoRed was normal with AFI 11, but at 33 weeks, 5 days, there was reduced fetal movements, sudden oligohydramnios with AFI 2, and steroids were given. And at 34 weeks, LSAs was done in a setup with inbuilt NICU and the pediatric nephrologist being there, pediatric surgeon being there, who catheterized the baby with difficulty after section, and later on did urethral valve fulguration. The baby is almost 6 years old now and doing well now. So that's the significance of even picking up in the 3rd trimester. Patient is ready for the treatment. Consultation has been done. The proper place has been decided for delivery, and we can save such babies. This was a case, again, 18 weeks scan was normal, referred at 26 weeks, and on ultrasound, what I see is a double bubble sign, as you can see here. And there is also a communication which is seen between these two bubbles, that is stomach and the duodenum. And we know for sure this is a duodenal atresia. And we know there are very high association with chromosomal anomaly. Amniocentesis was done. It proved to be a trisomy 21. And then the patient had to go through the committee and terminate the pregnancy. But importance is to pick them up, because these are late evolving. You may not find this double bubble earlier than 22, 24 weeks. So whenever it is picked up, you have to do genetic testing and the counseling and management based on the test. So benefits of picking up late anomalies is that some of them are treated. Some experiments are going on of urethral valve ablation in lower urinary tract obstruction. Some shunts, pleural effusion, vesicoamniotic shunts are done. Meningomyelocele, some shunts are being done. Antenatal consultation and keeping necessary specialists, as you saw in that case of luto, is also possible. It helps in planning of remaining pregnancy, the place of delivery, especially cardiac lesion, duct-dependent lesion, tertiary care center delivery has to be done, and prostaglandin can be given, and baby can be saved. Many other surgeries you can plan properly. Parents are mentally and financially prepared to deal with postnatal management. And overall, with this, with the teamwork of obstetrician, fetal medicine, sonologists, the consultant, the overall parental outcome improves. So remember, let's be vigilant. Don't take 2nd and 3rd trimester scan lightly. These are not just growth scans or well-being, but these are all the scans where we have to look at the anatomy as well. Now is the extension of my talk, and that is, we know that in pregnancy, after having looked at the growth disorders and some of the anatomical deformities, of course, we always look at the placenta, LycoRed, cervix. Now, placental location, we all know that 28 weeks, we all have suspected placenta previa, because 18 to 22 weeks is the gold standard when we look at the placental location. If we find that the lower edge of placenta is within 2 centimeters from the internal os on transvaginal scan, that's a placenta previa. And of course, it's marginal, sitting right on the os or covering the os. Then we all know we have been vigilant in monitoring. So we already diagnosed placenta previa. then we have to monitor closely this patient, even if the patient is asymptomatic and not bleeding. And we must be placenta minded, and we must not miss any placenta previa, because we all know how complicated it can be if the patient bleeds without knowledge of placenta location. Now, how frequent scans should be done when we are suspecting low-lying placenta at 18 weeks? Of course, 18 to 20 weeks, we confirm the location. Then all this in whom it is low-lying at 28 to 30 weeks, again confirm. 32 to 34 weeks, even if patient is asymptomatic. And of course, if it's a placenta previa, we'll be planning a C-section, and just before the section also, we have to repeat the scan. We have talked about placenta previa. Another very, very important aspect of placenta is placenta accreta spectrum. These days, with increasing number of cesarean section, we all know that whenever there is placenta previa, previous C-section, and anterior placenta, we all are worried about placenta accreta spectrum. Adherent placenta, placenta accreta, increta, or percreta, because there are lots of dangers to maternal life if it goes unnoticed, and if you just find out on table that this is adherent placenta. So how can we prevent this emergency situation? Well, ultrasound, there are imaging signs. Loss of clear zone in 70% cases. Myometrial thinning under the placenta less than 1 millimeter. Placental lacunae, which are large, irregular, sonolucent spaces, gives moth-eaten appearance. Here in the clip, you can see very well, these are large lacunae, and there is complete loss of hypoechoic zone behind the placenta. These are two very, very important signs. Just remember this sign, the moth-eaten appearance or the large lacunae, and then look at this at 32 weeks, the lacuna are so big. And when you put on the color, you are going to find out so many changes. Turbulent lacunar flow, utrovesical hypervascularity, bridging vessels, lacunar feeding vessels. But most important, as I said, look at the huge lacuna and look at the irregular flow in the lacunae. This is something you can never miss. Once you look at the lacuna, put on the color, you see the feeding vessel, you see the high flow in this lacuna, and then you are for sure you know that this is very, very high likely to go for placenta accreta spectrum, and we have to plan the delivery well. Well, as I said, the signs on ultrasound are important to pick up placenta accreta spectrum, but remember, the adherent placenta or loss of hypovascular zone behind the placenta is present in only 70%. That means 30% will not show that sign. Right? Even the lacuna and all will be there in 80% cases. That means 10 to 20% you may not get even lacunae. So what is most important in suspecting placenta accreta spectrum and monitoring in third trimester is your history. When your history tells you that there is a previous section, there is a placenta previa, anterior placenta, take each and every case as a placenta accreta spectrum and monitor delivery at a tertiary center. If there are more than one sections, more than previous 2 section, 3 section, 4 section, all the more necessary with anterior placenta to deliver that patient 100% at a tertiary center where there is a blood bank facility available, a multidisciplinary care team is available, because you know there can be dreaded complication and then you'll not be able to save this patient. So a stitch in time saves 9. So we have to counsel these patients right in the antenatal period, and when you are doing scan at 28-30 weeks, and tell them that they have to go to a tertiary center for a good outcome. Now, this is some further addition. We also look at the LycoRed and the cervix. And in LycoRed, we know we have 2 parameters. One is amniotic fluid index, the other one is deepest vertical pool. So what is the exact method of looking at the amniotic fluid index? It can be determined after 20 weeks of gestation. We divide the uterus, as you can see in the picture, in the 4 quadrants, and then pocket without umbilical cord or fetal part is what we look at, with the measurement from 12 o'clock to 6 o'clock position, and we sum up all 4 pockets. So this is how the all 4 pockets the measurements are done. Remember few points which are very, very important. The technique is very, very important. The transducer has to be held perpendicular to the floor and not obliquely like this. This is a wrong method. So it has to be perpendicular to the floor, and the maximum diameter of that pocket, vertical pocket, has to be taken. All 4 quadrants are total is done, and 5 to 25 is a normal range. Now, what is deepest vertical pool? Well, when you look at all 4 quadrants, when you find that the biggest pocket is the one which is between 2 and 8, it is normal. No need to go for other 3 pockets, because this is very, very perfect method of looking at your LycoRed. When it is less than 2 centimeter, it tells it there is oligohydroamnios. More than 8 centimeters, it tells us polyhydroamnios. Now, when should you use deepest vertical pool and when AFI? Well, subjectively, when you feel that the LycoRed is less, use deepest vertical pocket. And when you feel that the subjectively that LycoRed is high, use AFI. Why so? Because it has been found based on various studies that AFI tends to overdiagnose oligohydroamnios, and there will be unnecessary cesarean section. So whenever you subjectively feel that the LycoRed is less, go and find out the deepest vertical pool. If it is more than 2 or between 2 to 8, it is not oligohydroamnios. Do not act on that. Do not plan any operative delivery on that patient. Right? That's very, very important. So oligohydroamnios is a condition when AFI is less than 5, DVP less than 2, but we always rely on DVP when diagnosing oligohydroamnios. Now, when to act and when not to act when there is oligohydroamnios? Well, when oligohydroamnios is in association with fetal growth restriction, it's not a very important marker in decision-making of delivery. Dopplers are the one which should guide for timing of delivery and not your LycoRed amount. If Dopplers are okay, you can still wait with fetal growth restriction with oligo. But as I showed in the case of lower urinary tract obstruction, sudden decrease in the LycoRed with reduced fetal movements, I'll be worried of the pulmonary hypoplasia and fetal death. Their action is required. PPROM with complete oligohydroamnios or anhydroamnios, these are all the red flags which tell you, yes, there is a worry and we need to act, but not in fetal growth restriction. Polyhydroamnios, what is the clinical significance? Well, even in 3rd trimester, when you find that there is polyhydroamnios, previously no anomalies detected, we must again look for GI anomalies. As I said, the duodenal atresia may not have been picked up earlier. The TOF, tracheoesophageal fistula, the esophageal atresias, many GI atresias, some of the masses compressing on the mediastinum or thorax may present as just polyhydroamnios. So we need to look at the structures of the fetus again. If that's normal, we again look at the sugars with 75 gram glucose, because you know isolated polyhydroamnios also can be a sign of gestational diabetes, and then manage accordingly. Sometimes fetal akinesia sequence, which is usually picked up early in the pregnancy, or anencephaly, which is most probably is picked up early in the pregnancy, but rarely you may find with polyhydroamnios presenting in the 3rd trimester, and idiopathic also is a cause in polyhydroamnios. Cervical assessment, again, the gold standard is between 18 to 22 weeks, right? That's the time we look at the cervix, because we want to predict and then try and monitor that pregnancy closely with our progesterone support. But when we have already suspected that the cervix is short and we are monitoring in 3rd trimester, yes, 4 to 6 weekly, we'll look at the cervical assessment in the sagittal section. We'll try and look in the transvaginal section, the cervical length, which is from the internal os at the end of the hypoechoic V, as you can see here, till the external os. And the gold standard is always transvaginal scan to find out the cervical assessment. And based on that, we'll be taking all the actions. I hope, but in 3rd trimester, the monitoring and progesterone support is the way to go for short cervix. Nothing much can be done then. So because the action would have been done earlier in 18 to 22 weeks scan. So as I said, the 3rd trimester scan is a very crucial scan, not just 1, 2, 3, multiple aspects of pregnancy we get to know in our 3rd trimester scan. And therefore, we have discussed this, all the viability presentation, the growth disorders, the dating, the anomalies that we can pick up, the placenta, how to follow a placenta previa and placenta accreta spectrum and manage well, looking at the LycoRed-M cervix. All these things in third trimester ultimately is done because the final outcome we want to see as a healthy mother and a healthy baby by managing entire pregnancy and the delivery part well. And that's the reason I keep requesting all the obstetricians that as a chairperson for FOGSI Imaging Science Committee, I request all of you all to learn ultrasound, to fine-tune the skills of ultrasound, because every patient that walks up to us, whether in first trimester, second trimester, third trimester, will need ultrasound for better management. And so we all must learn ultrasound in pregnancy. With this, I'll conclude. Hope I have not bored with my long talk, but it was a request from Dr. Seema, so I had to extend my talk. Thank you so much for patient hearing. Thank you.
Oh,
Thank
this
you,
was
ma'am.
super and thrilling talk. Welcome, ma'am. Dr. Neeta ma'am is the chairman and HOD Department OBGY Asian Institute. She's my senior, my mentor also, and past president Faridabad Menopause Society. She's DNB teacher since 2004. Over to Anita ma'am to start the session for Dr. Aarti Tulani.
So I'm really glad and proud to invite Dr. Aarti. She is clinical director, fertility specialist, and scientific in charge at Mamta Fertility Hospital. She's the associate editor of Minerva Gynecological Journal, that is the Italian journal of Gynae and Obs. She's secretary Telangana ISAR 22-23 session. Faculty at the Kiel School of Reproductive Medicine, Germany, for the diploma course in reproductive medicine. She's the team member. Project Pelvis promotes free academic education online in fertility, gynecology, and laparoscopy across groups all over India. She's member secretary, Institutional Ethics Committee of Infertility Institute and Research Center, Hyderabad. She has several awards, publications, and journals and books written by her, and best being the National Award for Budding IVF Champion of the Year 2019 by Economic Times in National Fertility Awards in October 2019 in Delhi. She has the Young Academic Star in the field of infertility in South India by Star Time Media National Healthcare Awards 2019, Young Achiever of the Year in the field of infertility by India Best Doctors 2018-19, and more than 30 publications in national and international journals and textbooks. So today we have her here, and she's now going to take over and talk to us. Thank you so much.
Thank you so much, Anita Madam, and thank you so much to the Rewari Society for having me here. Dr. Bela, thank you for inviting me. It's such an honor. Dr. Seema ji, thank you so much for having me over here. It's an absolute honor and pleasure. And my namaskar to all the other co-faculty and the conveners, chief guests of honor present over here. So I'm very excited and happy to talk to you on a subject very close to my heart, which I'm very highly passionate about, and that is ultrasound. And I'm going to take you through a simple step-by-step method to screen the pelvis in the subfertile. And I've made it as much pictures and less explanations so that it is easy for everyone to understand, and the take home should be that each one of you present here should be able to screen the pelvis in a systematic manner thoroughly so that no pathology is missed when we are doing it in this manner. Now, with this as the background, let's start with why should we use the ultrasound technology to our advantage. Firstly, our primary role as a physician is so that we can give information to our patient so that we can have an accurate diagnosis and we can manage the patient well with the proper visualization of the pelvis, and so that we can share our observations with our patients. Our other primary role is, of course, helping our patient achieve a success of having a healthy baby, and ultrasound helps us in this endeavor. But then this is not what we want. This is not success for us, nor is this success for us, and nor is this success for us. Here, we are partly responsible if the patient lands up with such problems. So we have to be very clear that we are using ultrasound so that we can maximize our effects of treatment and we can minimize the complications and risks associated with the ART treatment. So that is our primary goal. And in this journey monitored by ultrasound, there are several steps. And I'm only going to today take you through the first step in detail, and that is the initial diagnostic scan. Then, of course, after we do the initial diagnostic scan and when the time comes where we have to plan a protocol for the patient, then we have the pre-treatment assessment. Then we do an ultrasound for calculation of dose for stimulation. We monitor the follicular phase and the endometrial response. Then we trigger ovulation. And when we are going ahead and doing an IVF, we use ultrasound for interventions like an oocyte pickup. And finally, we use ultrasound even for a ultrasound guided embryo transfer. So this for you is like an overview of where ultrasound plays a role in the journey from the follicle to the fetus. Now let's start with the step-by-step methodology. Is there a systemic rational approach to doing a proper scan of the pelvis? And so by the end of the talk, I'm going to help take you through the steps involved in performing a complete evaluation of the female pelvis and how we do it at our hospital. Now, let's start with the ultrasound toolbox. Remember that when you're doing an ultrasound, you need to do a transabdominal, a transvaginal, and a 3D ultrasound because it complements each other. Situations where the TAS scores over the TVS is when there is a mid-position uterus, when there are large dermoids, they are better visualized by transabdominal ultrasound, when there are large masses extending into the upper abdomen, when there are small ectopic pregnancies, or when there are cervical fibroids which may cause shadowing and obscure the visualization by a TVS. We should be using color Doppler when needed. It's a bidirectional where we look at the bidirectional flow. Power Doppler where you can pick up low velocity flows, and HD flow again where we can pick up low velocity flows. We use a spectral Doppler so that we can quantitatively assess the flow at the site. And we can also calculate our indices. We use also 3D Doppler so that we can get a spatial orientation of what we are looking at, the blood flow to the organ of interest. Why is it important that we do a Doppler? So that we can look at the presence or absence of flow, the abundance of flow, what is the direction of flow, what is the morphology of the vasculature, what is the branching pattern, what is the velocity. So all this gives us so much of information and improves the accuracy of diagnosis. So this is just a simple ultrasound toolbox we must have in mind when we are starting off doing a complete pelvic ultrasound in the subfertile. Now, with this as our ultrasound toolbox, let me take you through the concept of compartments. Now, there is an anterior compartment, middle compartment, lateral compartment, and the posterior compartment, which we have to look at. Now, let's start with the anterior compartment. When we are looking at the anterior compartment, you're looking at the bladder wall, you're looking for any thickening, any irregularities. Always do the ultrasound with a semi-filled bladder so that you can make out these minor abnormalities if present. Always look at this UV fold, the sliding sign, the way this UV fold slides away from the uterus. Is it sliding away easily? Or in this case over here, is it not sliding away easily, which means that there are associated bladder adhesions? Then also look for the ureters. That is, they are long hypoechoic tubular structures in the lateral aspect demonstrating peristalsis, and look for the presence of ureteric jets because this tells us about good ipsilateral renal function. Always look at the kidneys, whether they are placed correctly, whether there is any absent kidney, whether there is any pelvic kidney, because this is associated with Mullerian abnormalities, and if there is any pathology in the kidney like a hydronephrosis, which may happen if there is some sort of a pathology on that side of the pelvis in case of severe endometriosis. So this is a recap. When you're looking at the anterior compartment, look at the bladder wall, look at the UV fold, look for the presence of ureteric jets, and look at the kidney placement. So this is about the anterior compartment. Now let's look at the middle compartment. What should we look at when we are doing an ultrasound of the middle compartment? You're looking at the uterus, you're looking at the morphology, taking your measurements, you're looking for any pathology, and of course, when there is pathology, again, you use your Doppler. Now let's understand a little bit about version and flexion. The angle the vagina makes with the angle of the cervix is the angle of version, and the angle the cervix makes with the angle of the uterus is the angle of flexion. So when you say that there is anteversion, you know that this uterus is more towards the bladder. Retroversion, it means it is away from the bladder. Always see to it that your ultrasound examination is dynamic and real time. That is, you place one hand over the abdomen and you press your hand and bellot the abdominal wall and the uterus, because you want to see whether the bowel is freely moving all around the uterus or no, because this is sort of compromised in patients with a frozen pelvis or severe endometriosis. Look at the endometrium in the sagittal section, because this is where you take the measurement of the endometrial thickness. Also look at the endometrium in the transverse plane, because this is where you can make out splitting of the endometrium and you can pick up uterine anomalies. Of course, you should put in your 3D if you want to look at what is the type of anomaly we are dealing with, but then the transverse section tells you, whether there is an anomaly. Look at the myometrium, look for pathologies like myometrial cysts, fibroids, adenomyosis. Look at the endometrial cavity, look for the presence of any endocavitary lesions like polyps, like a submucous myoma, like the presence of intrauterine synechiae as well. When do you use a Doppler when you are looking at the middle compartment? Before starting stimulation, put on your Doppler. If you are seeing poor blood flow, this is when you really want to start your stimulation. But if you're seeing too much of blood flow just before stimulation, this means either there is high amount of estrogen or there is chronic endometritis, and this is not when you want to start your stimulation. When you want to differentiate between a fibroid, a submucous fibroid, and a polyp, again, put in your Doppler. A fibroid has circumferential blood flow and a polyp has the typical pedicle artery sign. When you want to differentiate between a fibroid and an adenomyoma, again, put in your Doppler. A fibroid again has circumferential blood flow and an adenomyoma has translesional blood flow. We use Doppler again in an IVF cycle before planning the transfer, because depending on the zone of blood flow, then you look at what are going to be your predicted pregnancy rates. When you are seeing an adnexal mass and you do not know where it's arising from, again, putting on the Doppler will actually guide you and tell you what is the organ from where that particular structure is arising. For example, now this is a patient with a mass here, and when you followed it up with the Doppler, you could make out the claw sign, meaning that that was a pedunculated subserous fibroid. Do a 3D when you're assessing the uterus, especially when there is pathology in the uterus, because this will give you a spatial orientation of where exactly the mass is and what is its relation to the junctional zone. Do not forget to look at the junctional zone when you're looking at the middle compartment, because this junctional zone is this sharp hypoechoic structure along the endomyometrial interface, and abnormalities in the junctional zone can indicate if there can happen if there is early adenomyosis or if there is some sort of a chronic endometritis. Do not forget to look at the cervix. This is a very often missed structure when a pelvic assessment is done. Look at the size, the echogenicity, the contour. Now, this is a very simple case demonstrating how important it is for you to look at the cervix. This patient came to us with a failure in the previous IVF cycle elsewhere. She had a large Nabothian cyst. A 3D reconstruction showed this Nabothian cyst sort of protruding into the cavity and causing some sort of an obstruction. And all we did was did a hysteroscopy, punctured the cyst, and the subsequent IVF cycle was successful. Again, this is a patient over here. You can see over here a polyp, a cervical polyp, and there was quite a bit of vascularity. Normally, one would want to just pull that, pull that polyp out in your OPD. But then when we followed the vascularity of where this polyp was coming from, you can see over here that the pedicle of this polyp was vascular and it was arising from the endometrial cavity. And if we went ahead and just tried to pull this polyp out in the OPD, it would have resulted in a torrential hemorrhage. Now, again, this is an example where this was a young girl, 25-year-old, infertile. The cervix looks absolutely normal, but on ultrasound looked bulky. We put on the Doppler. There was fire in this cervix. We biopsied the cervix, and she had a carcinoma of the cervix. So important to look at the cervix. Do not forget to look at the vagina, because over here you can notice that there was a vaginal nodule, an endometriotic nodule here. Usually the vagina is very smooth and supple. And when you are doing the ultrasound and going into the vagina, look for these irregularities. And if the patient is having a tender spot when you are putting in your probe, search more over there and look for any vaginal nodules as well. So this is the recap of the middle compartment. It may seem a lot to do, but believe me, over a period of time, it just becomes a second nature for you to look at all these structures in each compartment. So in the middle compartment, you're looking at the cervix, you're looking at the myometrium, you're looking at the junctional zone, you're not forgetting to look at the vaginal wall, you're taking your measurements and also documenting what is the version and flexion, looking for any pathologies as well. So this is about the middle compartment. Now let's talk about the lateral compartment. When you are looking at the lateral compartment, you are, of course, looking at the ovaries, and you're looking also for any abnormalities in the tubes. You're looking at all your measurements and the normal structures. Again, you're making it a dynamic examination, looking at the mobility, the elasticity, and the tenderness of the given organ that we are visualizing. Now, how do you perform an antral follicle count? Simple. Put the ovary in the center of the screen. It should occupy 50% of the screen. Look at the ovary in the transverse view and in the longitudinal view. Put your harmonics button on, because harmonics sort of gives more definition to the follicle. Any color can be used as long as there is less clutter. You look on 2D, you follow eyeballing. That is, you go from one end of the ovary to the other, count all the follicles between 2 to 10 mm in size, and measure when in doubt. It is always better to do an antral follicle count when you are doing a live scan, rather than take images or videos and look at the antral follicle count later. Based on this antral follicle count, you then classify the patient as having a poor reserve, a normal reserve, or a high reserve, or a polycystic ovarian morphology. Now, another important thing to note is, in the presence of cysts, many a times you may not be able to count antral follicles because these cysts mask these antral follicles. Also, in the presence of adhesions or para-ovarian cysts, sometimes it may be confusing. When the ovary is far away from the probe also, sometimes visualizing the follicles may be a difficulty. Now, when you're looking at the ovary, also look at the surrounding structures. For example, here you're seeing there is a tubo-ovarian mass. We'll talk about how a typical hydrosalpinx looks later on. You look for the presence of these peri-ovarian adhesions. You look for the mobility also of the ovary, whether the ovary is again sliding easily or whether it is adherent to the posterior aspect of the uterus. So as I mentioned, not only are you looking at the ovary, the stroma, the follicle count, you're not only looking for any abnormal cysts within the ovary, you should know pattern recognition of different types of cysts, how they look on ultrasound. How does a simple cyst look? How does a hemorrhagic cyst look? How does an endometriotic cyst look? The presence of papillae you should be able to pick up, and how a dermoid cyst looks you should be able to pick up. Now, how do you make out a ovarian, an intra-ovarian from a para-ovarian cyst? When you're seeing a cyst within the ovary, you see something called as the ovarian crescent sign, where you can see the follicles around the cyst. Whereas when you are looking at a para-ovarian cyst and you're insinuating your probe in between that ovary and the para-ovarian cyst, you can see that the cyst is actually moving away and splitting apart from the ovary. So this is called as the splitting sign. Now, when you're looking at something which looks like an endometrioma, how do you know what is the pattern recognition for an endometrioma? Typical ground glass appearance, poor vascularity. Yes, you should know what is typical and what is an atypical appearance with the presence of, if there are presence of any excrescences, or if there is high vascularization within the endometrioma, you know that is very atypical. Do a pain mapping as well. When you are seeing suspicious endometriomas within the ovary, you know that when you're going to pressurize and put pressure on that area, there is going to be a wincing, the feeling of tenderness, which the patient is going to tell you. Also remember that when you are seeing bilateral kissing ovaries, it is not as simple as just that the patient has, kissing ovaries and only ovarian endometriosis. Remember, this is a subtle sign of a more severe form of disease, probably associated bowel endometriosis and fallopian tube endometriosis as well. Now, with this information, what are you going to do? You're going to do your antral follicle count on 2D or 3D. You're going to look at your ovarian volume on 2D or 3D. You're going to pick up your stromal vascularity and look at the RI, and you're all then going to classify the patient as a normal, poor, or a hyper responder. And based on these ultrasound parameters, you can actually plan what is the dose of stimulation, be it in IUI, be it in IVF. There are several normograms available out there where all these ultrasound parameters are required so that you can plan the dose better. When do you use a Doppler? When you are looking at the middle compartment, the lateral compartment, when you are timing your HCG, where you're looking at the perifollicular blood flow. You need to know what is the RI and the PSV so that you can actually decide when is the right time to give your HCG trigger during your follicular monitoring. When you are looking at the perifollicular blood flow, if there is poor perifollicular blood flow, you know that the chances of having a poor quality oocyte is higher. When you are having better vascularity, you know your chances of having a better quality blastocysts are higher. Now coming to, can you see a normal tube on ultrasound? Usually no, but if there is fluid, like at the time of ovulation, you can actually take that as a time to look at the tube, look at the fimbria. The floating fimbria can be seen in the presence of fluid. Now remember that on 3D, only this intramural part of the tube can be seen. You should know how a typical hydrosalpinges looks. It is typically retort shaped and will have incomplete septa, and this is when you know that you are dealing with a hydrosalpinx. Again, when there is fluid in the pelvis, look for the presence of these peritubal adhesions. So when you move your probe, you can see that these adhesions undulate and oscillate under pressure. Very typical flapping sail sign, typical feature of peritubal adhesions. So again, a recap of the lateral compartment. You're looking at the ovary, you're looking at the follicle count, you're looking at the volume of the ovary, you're classifying the response of the patient. You're looking at the mobility, you're looking at the relationship to the surrounding structures, you're looking at the tube. If it is abnormal, you're looking at whether there is any fluid in the pelvis, which may give you more information about the fimbria and the presence of peritubal adhesions as well. And of course, if there is a pathology, you're going to put in your Doppler, you're going to do pain mapping as well. Now coming to the posterior compartment. Just give me 1 minute. I'll just want to drink a little water. Now coming to the posterior compartment. Now this is a little challenging, but with time, you learn how to scan the posterior compartment. What are you looking in the posterior compartment? Again, you're looking at sliding sign. You're looking at whether the bowels are sliding away or whether the bowel is adherent, like in this image over here, to the posterior wall of the uterus. You're looking for the presence of bowel endometriosis, and you are also tracing the bowels. Now, how do you trace the bowel? Now, remember, 20 centimeters of the bowel can be assessed by a vaginal examination, a vaginal ultrasound examination. You should know how basically the bowel looks. Now, you know that the muscularis layer of the bowel is hypoechoic or darker in shade, and then you have the hyperechoic submucosa, and again you have the hypoechoic mucosa. So here you can see we are tracing the bowel over here. So if we have this basic understanding of how the layers of the bowel look, and you continue to trace the bowel till how much ever you can trace the bowel. Here you see we are continuing to trace the bowel, and suddenly there appears to be some sort of an irregularity over here. And when we continue to, focus on what this irregularity is, this patient has a lot of tenderness when we are looking at this. And this patient had typical bowel endometriosis. How does typical bowel endometriosis look? As I mentioned, diffuse borders, hypoechoic in the shading, and it is firm and tender when pushed and usually not very well vascularized. Once you look at the bowels, once you look at the sliding sign, do not forget to look at even the uterosacrals for any endometriotic nodules in the uterosacrals as well. So you can see that success is nothing more than a few simple disciplines practiced every day. Now, I want to also touch a little bit, since we are talking about the basics, talking about all the compartments, I want to touch a bit about importance of ultrasound ergonomics. Now, what is ultrasound ergonomics? It is the process of arranging your workspace to make your job more comfortable, aiming to reduce the physical stress and resulting injuries associated with being a sonographer. Now, kid, always take time to set up your equipment, know what should be your position while sitting, while scanning, and always remember to take mini breaks. Now, this is like a beautiful ergonomics checklist you should have, especially if you're beginning to do scans, or you do scans continuously for a prolonged period of time without taking breaks. Know that when you're sitting down, your monitor should be an arm's length away. The top of the monitor should be just below your eye level. Your upper arms should be close to your body, and the keyboard and the mouse should be on the same surface. Feet should be flat on the floor and thighs parallel to the floor, and we should be sitting at a 90-degree angle with our spine straight if you want to avoid continuous sonography related injuries in future. If you're standing, again, this is the way your posture should be when you are doing your ultrasound. Now, once you have gone through the entire pelvis, do not forget to give a thorough report so that the person who is reading your report knows that you have, scanned all the structures within the pelvis in a very thorough manner. And when you see that there is a pathology, do not forget to describe what is the nature of the pathology seen. What is your impression? Do you think it's physiological or benign or malignant? What is your possible differential diagnosis? What should be the tests and requirement for follow-up scans? And always remember to discuss your findings with the referring doctor. And when in doubt, you have plenty of seniors in your locality who you can contact and ask for a second opinion or an advice. Now, this is just an example of how we, perform, how we draw line diagrams. Of course, my inspiration and mentor for ultrasound is Dr. Mamta Deendayal, and her passion for ultrasound is known. And because of this passion and this culture in our hospital, we see to it that when we see a pathology, we actually draw out, and this line diagram is very useful, not only for the patient to understand what is the type of pathology, she has, but also for the referring doctor to understand what exactly is the pathology present in the patient. So these are just some examples of ultrasound and line diagrams that we always put out and give to our patient. So with this as the basis, I want to end my talk with saying that an ultrasound machine to a gynecologist is like a stethoscope to a cardiologist. And we should have this in our mind when we are doing an assessment of the compartments. The anterior compartment, what should we be seeing? The middle compartment, what should we be seeing? The lateral compartment, what should we be seeing? And the posterior compartment, what should we be seeing? And if you are going to checklist all this while you are doing a pelvic ultrasound, believe me, my dear friends, colleagues, and seniors, 98% of the time you will pick up your pathology and you will have your diagnosis head on. So this is a profound realization I gained, after practicing for the last 16 years. And that is, infertility is the only specialty in medicine where there are 200 diseases, only 5 types of drugs, and only one real diagnostic tool, and that is ultrasound. And I want to thank all our infertile patients from whom we've learned so much. And of course, my team over here who have inspired us to strive harder. Thank you so much for this opportunity. And it has been a real pleasure to talk on a subject which is very, very close to my heart. Hi, Priya.
That's brilliant presentation, and hope to meet you again. I mean, real gems we are getting. Thank you, Dr. Bela. So may I request Dr. Shweta to conclude and thank Dr. Aarti for such a wonderful, elaborate talk. So may I request Dr. Brigadier Sunil Takia to start the session. He's a retired consultant from Indian Army, Professor Al-Falal School of Medical Sciences. He has received award of Chief Army Staff Commendation and GOC in Northern Command.
Thank you. It's being always good. I'll introduce Dr. Priya. Dr. Priya, who's located at Bhopal. She's consultant and head of the Department of Reproductive Medicine at Bansal Hospital, reproductive medicine practitioner and teacher. Both the qualities coming together. That's a great thing. And may I now request her to please carry on with her presentation.
So my topic again is something really favorite. We now classify fibroids according to their relation with the cavity. And now because we are actually paying more attention to them in our ultrasound, to this classification of the fibroids, and this is how we should be looking at them. Now, wouldn't go into the diagnosis much, but what I'm going to talk in my presentation is, first is we should always acknowledge, it's said that whatever we know or whatever we see, it is because we stand on the shoulders of giants. And today, all of us, while we do myomectomies, so often we do it open, we do laparoscopically, some of us also do robotic. We must always be mindful of the person who brought myomectomy to us, and that is Bonnie. We will touch upon how fibroids affect fertility. So in any patient who is trying to conceive, it is not uncommon to have women coming into our clinic who have not yet started trying. And we find that they have a fibroid. So what to do with them? A patient of infertility who has started trying is unsuccessful, and what to do in those patients with fibroids. And finally, we'll touch upon what to do when a patient of fibroid goes for IVF. So basically, it would actually be surprising for all of us to know that there was a time where every woman with a fibroid got a hysterectomy. So the credit should go to Bonnie because he was pioneer in organ preservation procedures. He was the first one to do a cystectomy, the first one to do a myomectomy. He, of course, has a lot of other credits in gynec, like the clamp or Verdheims. But what was behind this was a personal tragedy. So his wife had fibroids. She had a hysterectomy at a young age, and because of which they did not have kids. This prompted him to write that famous monograph on fibroids, which has actually lasted. And this is one of his publications, his letter to the editors, which where he says that I have strenuously advocated myomectomy in preference to hysterectomy in all those cases where the removal of uterus is liable to be followed by undesirable psychological effects. And conservatism, what he practiced almost 125 years ago, is what we are after even today. So what is the present and what is the evidence at present? In my talk, I'll just focus on what the evidence says. There are places where the evidence is a little gray, where we don't actually get guidelines, but it is very important to understand in our field the uncertainties that are there. So in medicine, one can never be too certain of anything. And it is always very, very important to be mindful of the fact, because what we know as a gospel truth today is liable to change very quickly as the volumes build up and as we share our data. So there is a big difference in fibroid prevalence, all of us know. And practically, Black women bear the brunt of most of the fibroid burden in the world. In fact, almost every second Black woman has symptomatic fibroids. Their fibroids appear to be little different from what we see in other races. If we talk about India, this is a publication by the Ministry of Health and Family Welfare, and our numbers are also not small. So in our women also, 20 to 30% of women have fibroids. Now, what are the factors which make a woman more prone to fibroids? So definitely parity is one very big factor. And as we see in our own practice demography, if we see women who postpone pregnancy, women who are having low parity, nulliparous women are more likely to land up with fibroids. But of course, there is a lot of racial variation as well. And probably there is some influence of the xenoestrogens that are there in our environment, in the food that we consume, in everything around us, that is probably adding to the history of fibroids. Now, when it comes to the management, we also must be, this is a very recent publication this year, last year's from Fertility Sterility, which says that there is a lot of disparity. There is a lot of disparity in how fibroids are diagnosed, treated, so much so that it has actually become a racial point and a point of contention for many countries across the world. Now, when it comes to natural fertility, this is a review from Reproductive RVM Online. And Soumya, all of us know, has got a large volume of work on fibroids. In fact, he was the one who presented the first meta-analysis, which we will be discussing subsequently. And in this, he looked at how was there a temporal relationship and how actually fibroids were affecting fertility. So if you see these three graphs, when we compare the frequency of history of infertility in a woman with and without fibroids, you can see that the diamond is well on right side of 1. So women with infertility have a higher prevalence of fibroids. Now, similarly, so there is an increased incidence rate ratio. There is a common odds ratio, which is almost twofold. That means the odds of fibroids in infertile women is almost double that of women without infertility. So this means that there appears to be an association, but is that association enough to be a causation? We don't know. And this is the recommendations of American Journal of Obstetrics and Gynae. And now all of us agree and have seen that it is the submucosal fibroids which have the highest effect on fertility because they distort the cavity. Subserous fibroids have little effect, but intramural fibroids also, now there is a very big body of work which is building up, which is actually now showing that smaller and smaller size of fibroids are actually affecting the fertility. Now, as obstetricians, as gynecologists, and as even reproductive medicine specialists, we are not just interested in making a patient pregnant, and fibroids increase the prevalence of all these adverse obstetric outcomes as well. And in fact, not only these outcomes, but also abnormal placentation, placental abruption, and malpresentation is increased in women with fibroids. So, whenever we see a woman, so this is about the women who are trying to conceive and have fibroids. Now, what about women who are infertile and who present to us and on ultrasound we find that they have a fibroid? We all know that we look at the number, we look at the size, we look at the location, but it is very important that we never treat a report. We always have to consider the couple as a whole. What is their duration of trying? What is the status of the ovarian reserve? And what is the female age should also factor in when we plan for treatment. Now, what are the mechanisms? We all have learned this. Probably it's a hindered gamete transportation. Probably it's some problem in uterine contractility. So these are the reasons that we have learned when we were doing our post-graduation. But now there is a very big body of work which is growing, which is saying that it is the extracellular matrix component that affect the endometrial cell growth and function. And this affects the vessel remodeling. And we know that it is the vessel remodeling which is responsible for implantation, for placentation, and for the subsequent growth. And probably this is what is going to be the focus of the research in the future. Also, there is going to be a difference in the junctional zone. We know that junctional zone is very, very important when it comes to adenomyosis, but there is a body of evidence which shows that abnormal vascular architecture and junctional zone contractility also contributes to the results. Now, all of us have always thought of uterus as a sterile zone. We always thought that vagina is full of organisms, but uterus is a pristine organ which does not have a microbiome. But practically now, when we are doing tests like PCR, like next generation sequencing, we know that uterus is also a site of microbiome. Although they're present in smaller numbers, but they are there. And there is some recent evidence to show that fibroids can alter the endometrial microbiome. Now, we all know that the submucous fibroids will improve the pregnancy rates by double. So if you have a submucous fibroid, probably you should never push this patient to try normally or for IUI. You have to remove it because the implantation rate is going to be significantly lower and the ongoing pregnancy and live birth too. But when it comes to a Cochrane review, we have to understand that it pulls all studies together with lot of variability in the sizes. So even then, the review shows very, very clearly that even intramural fibroids, whenever we see, it always favors the intervention. Although the odds ratio is on both sides of 1, so there is a lot of question mark which is raised on this. But for submucous fibroids, the effect appears to be clear that there is a improvement in the pregnancy rate. Now, what about patients who are going to go for IVF and they happen to have a fibroid? We know that if it's a submucous fibroid, we'll take it out. If it's a subserous fibroid, which is not very big, we'll probably leave it as such. But what about the main question, that is effect of intramural fibroids on IVF outcome? So that is where the gray zone lies, and that is what we are going to discuss today. So there are around 4 to 5 articles or meta-analysis which looks at this, and this is one of the earliest. This was published way back in 2007, and he said that submucosal and subserosal fibroids do not affect, but intramural fibroids. This review by Sesh Kamal Sunkara, who we know as a very prolific researcher, and she's collaborated with a lot of Indian colleagues also. She said that the intramural fibroids, even smaller ones, will significantly reduce, and the reduction is almost to the tune of an odds ratio of 0.5. So that means at least halving of the pregnancy rate. Now, this article in 2018 included all the studies that Sunkara's study included and some more. And it definitely showed that these 28 studies, non-cavity distorting fibroids will significantly reduce the live birth rate after an IVF. So, to conclude, even women, those fibroids who are not encroaching the uterine cavity, they will have an unfavorable IVF and ICSI outcome. So this is the summary of the studies that I have quoted, and all of them you can see that the odds ratio favors removal of the fibroid. But it is not so straightforward, because many times we find that the fibroid is really small. It's just 2 centimeter, 3 centimeter. So what we follow in our unit is any patient who is planned to undergo an IVF and has a fibroid which is not encroaching the cavity, is less than 4 centimeter, we try and avoid the surgery and the patient is taken directly for IVF. Now, if the fibroid is between 4 to 6 centimeters, we discuss it with the patient. More than 6 centimeter, for sure, we are going to advise a myomectomy. Between 4 to 6 centimeter, if the patient has a previous failed IVF, then it is a no-brainer. This patient goes for a myomectomy. In case the patient is willing to go for an IVF cycle without a myomectomy, we will be happy with that and we'll go ahead with it. Now, this is a very contentious issue, because what happens is that the patients always want to avoid surgery, but they also want to fall pregnant. So again, in this zone, it's a shared decision, because the evidence does not seem very, very clear at this time. Now, this is the latest review by Infertility Sterility. And as you can see, even here, in intramural fibroids less than 4 centimeter, also there is a trend towards improvement in pregnancy rate with a myomectomy. And in fact, it will surprise you that even intramural fibroids, although there's just one study with maybe 64 patients, but that also shows a trend towards improvement in myomectomy. So probably now the evidence is emerging that we probably should be little more liberal with doing myomectomies in women, because a failed IVF is actually a catastrophe for the patient, especially if the patient is paying out of pocket. Now, so removal of intramural myomas should be considered in women with infertility, especially type 3 fibroids. And this study says that the size 2 centimeter or larger. Now, it is not so straightforward, because a 2 centimeter fibroid is well inside. So it's not so straightforward to do a myomectomy for this. Sometimes, in actually searching for that little fibroid, we may be causing more myometrial damage and scarring. So in these situations, an intraoperative ultrasound, and if somebody does their own ultrasounds, it makes a very, very big difference, because then you know where exactly to give the incision. When it comes to this Cochrane review on hysteroscopy for treating subfertility associated with suspected major uterine cavity anomalies, in the subset of women who had a cavity distorting fibroid, they found that myomectomy improves the outcome. Now, what about outcomes after myomectomy? So definitely, if intramural fibroids are removed, IVF outcomes are improved. And whenever a patient has had a myomectomy versus a patient who never had a surgery, myomectomy does not appear to reduce the implantation rate, because one would always have a fear that my myomectomy may cause some scarring, may cause reduction in the endometrial receptivity, or maybe subendometrial scarring, but that doesn't appear to be true when we examine the evidence. So we know we have different methods of removing the fibroids, but the gold standard at present is definitely laparoscopic surgery. And of course, this is the Cochrane review, which we published almost 10 years ago, and we said that laparoscopic myomectomy is the way to go. Now it has become the standard of care. Of course, there's a lot of debate regarding the morcellation. We cannot go into it for the shortage of time. But to conclude, fibroids may interfere with natural fertility and subsequently with the childbearing. Submucosal fibroids and cavity distorting fibroids have to be removed. Subserosal fibroids take a call depending on the location and the size. Non-cavitating fibroids more than 4 centimeter definitely should be going out. Less than 4 centimeter also, evidence is rapidly emerging that removal might improve your IVF outcome. So thank you so much for your patient hearing, and I'm again really sorry for the interruption and my delay in starting the presentation. Thank you so much.
Thank you, Dr. Priya, for such an exhaustive, elaborate, and evidence-based talk. Over to you, Anubhuti.
Yes, thank you, Seema ma'am. Thank you, ma'am, for giving me this opportunity to conclude the session. It was a really great CME, and a special thanks to our chief guest, Jaydeep sir, our President FOGSI, under whose guidance the webinar has been possible, our chief guest and our guest of honors, Dr. Madhuri ma'am and Dr. Girija Wagh ma'am, who have always been a big support to us. We really honor our speakers, Bela ma'am, Priya ma'am, and Aarti ma'am, for enlightening us with all the new updates and obviously help us freshen up our basics as well. The expert opinions from our senior members, our chairpersons, has truly added cherry on the cake. A big thank you to Alka ma'am, Pooja ma'am, Sunil sir, Sonu ma'am, Anita ma'am, and also Shweta ma'am as well, who have added pearls of wisdom to our CME. A big thanks to you, Seema ma'am and Girija ma'am, for taking up this initiative in spite of your busy schedules. And Seema ma'am, you have always been a motherly senior to all of us, to me especially, and have always helped me in my practical aspects and in my academic fronts also. And how can we not count our ever enthusiastic audience, because of whom the zeal and to organize all these CMEs have always remained evergreen. I think I should also thank Jagsonpal for supporting the event. And it is a great thing that we have ended up on time. And I think we have all the audience, as far as me including in them, have really gained a lot from this CME. Looking forward for so many more CMEs from our seniors as well now.
Thank you very much, ma'am. And it was a great webinar. So much of learning, even for us. Ma'am, Jagsonpal is committed to health, science, and service. And we'll just play a small video, brings to you our brands as a reminder for you. So these are a few brands which the IVF specialists would be interested in. We have LycoRed-M tablets, which are recently introduced for male infertility. And we have Dynogest 2 mg tablets. The first people to bring out the tablet formulation of Dynogest was Jagsonpal. EndoReg comes in a trip of 14 tablets. So the days of the week are mentioned on it so that there are no chances of missed dose. It's a calendar therapy pack. EndoReg. We have Yuliprist to manage fibroids. That is Yuliprist acetate 5 mg. Of course, the dosage regime is a little tricky, which all of you are aware of. And also the LFT needs to be monitored while on Yuliprist. Fibrostone 25 is our Mifepristone 25 mg tablet. Thank you so very much. And we look forward to being with you all again.